state legislature. There was, I think it was the 18th of February or January? 11. No, it was supposed to be the 18th. It was supposed to be the 18th of the month, and we were going to have people from Consumers Choice and everyone there at this legislative hearing. And she just went ahead and moved it up 1 week. And nobody knew about it, so there was only one side of the issue presented.
Well, they told the dental board.
Oh, they told the dental board, okay.
The executive director of Arizona State Dental Association was there.
Right, I'm going to repeat it so you can hear it there in case you couldn't hear Terry, that the executive director of the dental board was there. Of course, he was informed and it wasn't passed on to anyone else. So regardless of what we've been hearing from the boards, they're just turning around and sneaking around the other end and doing what they're going to do anyway. We've really got to be on our toes. If anybody wants to have another one of these flyers, if you tossed it and you want another one, come see me. I'll be over there. Thanks a lot. Okay, thanks, Chris.
You know, it seems like we've gone beyond science in this battle. I mean, here's all the evidence, and we're supposed to be a learned profession, dentistry and medicine, and I don't think we are. And to me, of course, I believe everything is a conspiracy. I really think that, you know, you put a little fluoride in their water and mercury in their teeth, and you got a nation of idiots.
Amen. That's right.
And I really think this. I think at this point now it's become a plot for some reason. I mean, okay, mercury's bad, but we're going to keep shoving it into your teeth. And if you're going to be a sole individual and say, I don't want to do that because in my heart I know that's right, we're going to take your license. Well, God bless you all for doing the right thing. You have to do the right thing. You have to do what your heart tells you, number one. I had a call from an endodontist the other day from California who had seen a patient of mine take sutures out or something, and he said, I've heard about you, I understand what you're doing. And I said, what do you do? He said, I'm an endodontist. I said, when are you going to stop killing people? He says, hey, I got to make a living, you know. I said, you SOB, you got to do the right thing. You can't do this. I said, well, yeah, I can understand that some of these teeth can be infected and spread some of this, but we have antibiotics and stuff. I said, they don't work. Here's the literature. And if you want to argue with me, and by the way, I have a $100,000 bet, standing bet with the ADA, anybody that says cavitations do exist. So if you want to pass that to your colleagues or anybody else that said this is crap, I have a $100,000 bet saying that I'm right and the ADA is wrong. Nobody's taking me up on that. Okay?
I did the same bet on the internet, and I just want to say this. I put that out on the internet because I want a dental forum every day I'm home, and that's not lately. It hasn't been very much. I put it up, and I got one, and I don't mind telling you his name because he's a real asshole if you're pardon expression. His name is John Jefferson from the Bay Area. And just argues with me all the time that I'm an alarmist and that the root canal is perfectly safe. He's done 9,600 of them and he's never had a failure. Well,
ask the endodontist when the last time he took a tooth out and sent it in for biopsy or a culture.
Right.
Ask
anyway,
him that. Ask an oral surgeon last time he took a tooth out and biopsied the tooth.
And I said that, I sent him a deal. I said the same thing that I got $100,000 that we pull 5 patients off the charts and we do surgery on them. Chris volunteered to do the surgery. I said, if we find one patient that doesn't have osteonecrosis at the root canal site, I said, you get our $100,000. If we find all 5 of them have it, I get your $100,000. They all came back and said, you're not going to sucker us into that bet. They don't exist, but they're not going to sucker us into that bet. So
you talk about New Jersey. That doesn't surprise me. I was born in New Jersey, and I left when I was a kid, went to Michigan, and I raised the IQ in both states.
Right.
Please, I want to remind you to see our exhibitors. We have lunch today sponsored by pleomorphic products. I'm sorry. I want to get started now. I want to introduce my dear friend, Dr. Klinghardt. He doesn't need an introduction, but I'm going to give him one. The title of his work. Kling who? Physician, heal thyself. How important it is nowadays to take care of ourselves. And we've talked about taking care of yourself as a healer, and I'm the last one to take care of myself. And I realize there's only so many years left in this body, but you really have to take care of yourself. Practice good dentistry. If you're taking out mercury fillings, you use a mask. You use oxygen on the patient. I get patients come back and say, this guy took my fillings out, and God, he did it wrong. He didn't have me wear oxygen, or he didn't use a rubber dam, or he didn't have suction. Cover yourself, because patients will complain, and they'll blame every dentist. Well, he didn't take out my mercury right, and I got real sick. Well, I have a hard time with that. But anyway, cover yourself. Wear that 3M mask that has the charcoal in it. Wear an oxygen mask. Make sure the patient has oxygen on. I'm not real big on rubber dams. I don't do general dentistry anymore. But make sure your rooms are clean, hygienically. Get rid of your mercury. Okay? Practice safe dentistry. Wear a condom. Do something like that. Dieter, are you ready? You want to come up? Okay, his title of his work is Physician Heal Thyself, Neurotherapy in the Teeth. I mean, what else is there? He covered it all. Dietrich Klinghardt.
I just want to, before we get official with my thing, I just want to add something to the last section on the politics. Ara and I went to a meeting sponsored by the National Council Against Health Fraud, which is the same group that's behind almost any prosecution of any doctor, sponsored by the pharmaceutical industry, where all the monies come from. And so we attended a meeting which was put on by the University of British Columbia in Vancouver. There were about 200 people there. And the speaker first outlined who was the main guy. I forgot his name. Well, Goldstein was the sideshow, but John Dodds, yeah, dentist from New York, and he set out the meeting first, like outlining what the scientific criteria are that you can tell by whether a treatment modality is fraudulent or is real. And he set out, to first, like, it was a placebo-controlled, randomized, double-blind study that should stand behind any treatment that is kosher to do. And then he said what also is how you can also recognize fraudulent treatment is that the speakers that are speaking up for those kind of fraudulent things tend to insult other people and work with that kind of style of lecturing, bad-mouthing other people, getting personal, rather than staying within the science. And then he proceeded for the whole day talking to us without leaving time for questions and insulting people, getting very personal, not presenting any double-blind studies for dentistry. And then several people in the audience said, well, here's a double-blind study on placebo control that's been repeated in several centers on homeopathy. Well, that doesn't count because it needs to be repeated many more times before we can accept that. And then somebody said, well, and here's a study on acupuncture. Well, that was just one study, and that doesn't count. It needs to be repeated in many centers. And so at the very end, when we had like 10 minutes for questions after enduring this for a whole day, I asked the question, well, so I'm a scientist from the state of Washington, and I'm really interested in, and really like, would you just finally at the end, now that you've been kind of holding out on us a little bit, really kind of give me just a quote, so I can take that home and relate to my patients, of the randomized controlled double-blind studies that show the safety on the amalgam fillings and the safety on the root canals. Well, that would be unethical to do a study on that, to not place amalgam fillings in one group. And that was sort of like his answer. That was his answer to the question, but it kind of exposed very much the hypocrisy, of the whole thing. And it felt very much, the feeling in the room was very much that there's these two guys, sitting on a sinking ship, with that sort of like English stoic kind of pride, so being arrogant until the last moment, when the water kind of, kind of comes up here. There was a feeling in the room, and I think, and it was very clear, the rift that dentistry has exempted itself from science, that there's a world of science which has moved way beyond these issues, and there is a world of dentistry which is sort of like a little fortress kind of swimming in the ocean of science, kind of slowly sinking. That was sort of like the image that came to many of us, and I think if we stick with it, we're going to be doing fine. So to change the tone a little bit, I want to sing a song with you. Not that I'm a great singer, but I do have a loud voice. And this is a song we're singing together. I give you the words on it first. I sing one round of it and then sort of... No, I do it like this. The mic wouldn't hold up on this. So you just cannot join in. It's a song with a very few words and kind of keeps coming round and round until you get it, and then we do something else. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love with myself again. So I feel my feet walking on the land. Just gonna say that once. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love with myself again. Okay, let's try that. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love with myself again. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love with myself again. And now, this is from Sufi dancing, from a tradition where the main part of the thing is to sing loud. This is to open your autonomic nervous system. Yeah, we found with various testing that we did that this is the easiest way to open blocked regulation, to open the autonomic nervous system, to clean out your interference fields for the day. They may come back when you stop singing after a while, but while you're singing and for a couple of hours afterwards, there's a tremendous measurable change. But it only happens when you sing loud, so your whole body vibrates from the toes to the head. I didn't say sing right or correct or within tune, just loud. So let's try that one time. Yeah? And loud is like the mouth wide open. Okay, let's try. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love. No, louder. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love with myself again. And now we do one more thing. We do some hand movements with it to get the body open a little bit.
Huckster.
I feel my feet walking on the land. You just kind of, actually let's stand up for this one, so it's a little easier. So I feel my feet walking on the land. You put your hands so down as if you want to soak up energy from the earth through your inverted satellite dishes. And putting your hands down like that. I feel my feet walking on the land. Greeting the day with an open hand. You really stretch up, greeting the day with an open hand. My heart is singing as the day begins. And then a little bow. I fall in love with myself again. Yeah? Bowing to yourself, to the suffering and the struggling you and the blissful you and whatever. Okay. I feel loud. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love with myself again. Louder. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love with myself. Last time. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love with myself again. Close your eyes for a moment. No clapping. Close your eyes. Put your hand on your heart. Now we sing it one more time very softly, just as a love song to yourself. I feel my feet walking on the land, greeting the day with an open hand. My heart is singing as the day begins. I fall in love with myself again. closed and just indulge in yourself a little bit. And just enjoy that little bit of light moving in there. Okay, why don't you take a seat? Chris, would you stay on time? No, it was like half an hour. Okay, so first thing I want to do is like give you a little bit of a State of the Union address on the dental issues as they present themselves to an outsider, to a physician, but with a neural therapy background. And you know that Honecker was both a dentist and a physician. So from the very early days of neural therapy, dentistry has been part of this teaching. And I spend a lot of time in dental offices, mostly as a patient, but also as a researcher. And maybe a few words of how I got myself into the dental issue deeper than I ever wanted. It started with that I had a mouthful of amalgam fillings, and I grew up in the after-war years in Germany, and many of you may be aware of this, but some aren't. You know, my mother was actually starving when she had me. That was actually was not very good in Germany, like for many years after the war. And many of us kids, you know, grew up with definite defects, you know, in our biochemistry, in the bone skeletal development, and so forth, and have been damaged. You know, there's a whole generation of, you know, kids quite severely damaged, mentally, physically, you know, biologically, immune system-wise, and so forth, based on malnutrition early on. And so I was one of those kids, you know, and every one of us kids, you know, when we were in our teens, had a mouthful of amalgam. I mean, mouthfuls like you see them maybe sometimes from immigrants from England and from Poland, but you don't see them in American mouths. I haven't, you know, not that amount, you know, where the teeth are virtually not only on the chewing surface, but on the sides, you know, was amalgam, and they were basically amalgam crowns, you know. And so by the time I was 25, I had rheumatoid arthritis, and I was told, you know, never practice, you know, because I should get ready for retirement, basically. And totally unrelated, because nobody at the time, you know, told me that amalgam would be bad. But I was going to go and not die in Germany. It was sort of the vow I made to myself. I'm not going to die in this country. I'm going to leave. So I went to India to stay there, you know, stay with a guru and in a mountain somewhere, and, you know, sort of figure if this is the end, you know, at least want to have it gracefully. And before going to India, I decided, well, at least I want to, you know, I knew it was very difficult to get access to dentists in the mountains in India. So I went to a dentist and asked him if he could take all my amalgam out and put gold onlays or gold crowns in me, because I heard that those would last a lot longer than the amalgam fillings. So he did, and I was within a few days of the removal of the amalgam in my mouth, that my arthritis pain stopped, and you know, I made a complete recovery within a year or so after that. But it was, you know, the onlays were put in by dentists who didn't know anything about the bite. It totally destroyed my bite, and I learned everything about occlusion and TMJ there is to learn over the next 10 years. And within 2 months, after the last crown was put in, the next day I was on the train and then a bus to India, and had several bouts of diarrhea during the time when we know now my mercury levels in the blood were the highest, and I got severely dehydrated. And within 6 weeks of that, I was in kidney failure, somewhere in a motel in southern India, about 200 miles away from any medical facility. And had the luck that I was traveling with my girlfriend, then, who was a medical student, who went to an electric power station, it was about 50 miles away, they had a little medical setup there, stole at night all their IV equipment that they had, which was about, you know, I don't know, maybe 20 bottles, you know, of IV fluid, and saved my life. And actually at the late end of that, when we were running out of IVs and I was kind of coming out of a coma, we infused coconut juice, which was the only thing we could find. We used green coconuts. We were told that would work, and I said, hey, try it, you know, because I couldn't take anything in my mouth. And anyway, that was the beginning of a long journey, which started me so basically as a dead man, and I sort of I have made a long recovery, but I'm very empathetic about certain issues in dentistry, and are not swayed by medical boards and politics easily, because of my own experience. You know, when you get to that life and death kind of realm, then politics sort of becomes very ridiculous and sort of a side issue. I want to review with you as very briefly like some of the things I feel constitute the current knowledge in dentistry. Let's kind of quickly kind of go over the metals issue. So there's two camps, there's science and there's dentistry, and I'm just now talking science. In science it's very clear that mercury in the body is a very toxic material. It's a neurotoxin that creates severe dysfunction first in the unmyelinated nerves, the autonomic nervous system, then has a high affinity to the hormone-producing glands, which is the adrenals, ovaries, testicles, and then the hormone-producing glands in the brain, which is the hypothalamus and the pituitary. When you place an amalgam filling, thyroid, sorry, yeah. When you place an amalgam filling within 24 hours, all those glands are impregnated with mercury. And we know it attaches here to the sulfhydryl groups, it paralyzes the mitochondria, it makes those hormone glands dysfunctional. That means basically everybody who's ever had one or more amalgam fillings has some hormonal dysfunction. And these metals are bonded very, very tightly to those sulfhydryl groups. That means they don't have a half-life there. We're always told, you know, what's the half-life of mercury in the brain? Well, there is no half-life. It gets in, it stays. We did some dissections on cadavers, on autonomic ganglia, and on the hormone-producing glands. They're full of mercury when you dissect them in any body dead who's ever had an amalgam filling. I mean, it hasn't left the body. So, and the science of that is out. You know the studies. The group IOMT, International Academy of Oral Medicine and Toxicology, is internationally the forerunner, the pioneer. I think everybody who's interested in these issues or involved peripherally should be a member of that group, because most of the money goes to research, and the best studies have come out of that group, you know, from BIMI and Lorschade and Calgary. So that's just a little bit on the amalgam. So amalgam should be removed. It should be removed in a safe way. A few things about the removal that I think you dentists, most of you know, but there are some controversial issues. For example, Downdrawer in Germany showed when you give the patient nasal oxygen during the removal, nasal oxygen opens the blood-brain barrier, and it's not a good idea. Yeah, patients should have their own air supply, but it should be compressed room air. It shouldn't be oxygen. Yeah, I just give you a few pearls here of things that are hard science that we know. Another one is during the removal process, the speed of the drill. You know, we've gone from a slow speed to high speed. Now the high-speed drill, the Germans have shown, overheats the tooth, the dentin tubules, and creates little scars in the overheated dentin tubules, which then act as interference fields. That means this tooth becomes like a living scar. Can give you migraine headaches, gallbladder disease, pelvic pain, and other things. So the last layer of drilling should be done at slower speeds to avoid the overheating of the bone. Now, slower speeds, I don't say you have to use a slow speed drill, but you can tone down the speed of your high-speed drill to anywhere between 20,000 and 40,000 RPM seems to be safe, and you work with very low pressure on the handpiece on the drill, you know, and move. You know, if you drill on several teeth, do a little bit on one tooth and the other tooth to always allow time for cooling down of the dentin. This is an issue that's been very overlooked And so many of these teeth, you know, are living scars, you know, that many dentists leave behind. There's also, like, from Boyd Haley now, some new research he sent me that shows a very high suspicion that necrotic areas in the jawbone may be created by the physical vibration of a high-speed drill. The high sound pitch that's basically given off at 200,000 RPMs creates a resonance in jawbone that creates necrotic areas in jawbone. It has been proven that there's a lot of evidence in the scientific literature. Again, like talking not to use the high end of the RPMs that are available for you. I just try to touch on some of the issues here that are out in the scientific literature. Regarding the rubber dam, we know that mercury vapor does go through the rubber dam. It does go through latex gloves completely unimpaired. However, the rubber dam does catch the major pieces of mercury lumps that are broken off. So, depending on your removal technique, I still think the rubber dam may be a good idea, but you should use the suction, you know, the Swedish suction piece that gets put over the tooth. Cleanup, okay, the cleanup system, to avoid mercury vapor. Again, if you swallow an amalgam piece during removal, only 5% of that mercury enters the general system, because there's very little absorption, because mercury binds very tightly to the food fiber in the gut, in the food material, and it's methyl mercury that ultimately is created by this, which binds stronger to the food in your gut than to the gut wall. So only 5% of that get absorbed. However, the mercury that gets vaporized, that you inhale, 85% of that enter the system by inhalation, and almost 100% of this inhaled mercury stays in the system lifelong, does not have a half-life, because inhaled metallic mercury passes through all the barriers in the system. It passes the blood-brain barrier effortless, and then this inhaled mercury vapor, metallic mercury, once it gets inside the cells, gets reduced by catalase and becomes Hg2+, which then gets firmly bound inside the cells and doesn't leave the cells for the rest of the life of this patient. We don't have any evidence that we have any method right now to remove this intracellularly bound mercury by any means that we know.
The comment on the cilantro thing
Yeah.
that you gave out, somebody gave out a while back. Does
Yeah.
that work?
Yeah. I talk about the detox when I talk about, like, what are we doing for our own healing in this regard.
In the process of cell turnover in our bodies,
Yeah.
different layers,
Yeah.
the cells slop or
Yeah.
destroyed, does that mercury get recycled into another cell?
Well, you know how the cells duplicate themselves. You know, they duplicate by division, and so the cytoplasma that was in one cell before is now in two cells. And when the cell completely dies and gets destroyed, that mercury gets released, and so we have periodic bouts of mercury toxicity. Yeah, they are higher at night when there's more cell death than during daytime, but there's also more regeneration going on. So at night we always have periodic shedding of mercury in the system, which we can measure through resonance phenomena with the muscle testing. Can demonstrate that there's bouts when shortly after growth hormone peaks at night. You have a lot of cell division and cell death, and that all happens as a result. It's all tied in cycles together, and you can actually time at night when you do the MTS challenges at night. You often get much higher yields than when you do it during daytime. So there is periodic extravasation of mercury into the connective tissue that then enters immediately the cells again. Yeah, so it kind of is a rhythm of mercury being inside the cells and outside the cells. However, brain cells, as you know, live for 120 years, yeah, and they don't divide. And so once it's in the brain cell, it's in there for 120 years, which is pretty long. So you have to wait a long time for that to come out again. So we've been looking for ways of displacing the mercury from inside the cell to the outside, and hopefully, and we may not have enough time to get in all the details of that, but we've made great progress and detoxing brains. I've have now some cases, you know, a good level of mercury in the urine when you do a DMPS shot is like 50 micrograms to 100 micrograms. And I can now reproducibly, with my method, get people to shed over 1,000 micrograms in the urine. And my highest value so far is 3,000, just by combining good neural therapy, the cilantro, the chlorella, little DMSA, and DMPS, and giving the DMPS shot at the right time, where you get huge releases of mercury. But we hopefully get into that. So this is just on that aspect of the fillings. The plastic fillings, there is now good evidence that if you use if you use 2 or more plastics in the mouth, that means, you know, one plastic material, one bonding agent that has different kinds of plastics in it, that they have estrogenic effects. That means they occupy the estrogen receptors on the cells, driving that part of the system, meaning in women it is creating increasing risk of breast cancer and certain types of other tumors. In men it is feminizing, you know, and many of you will have observed that, if you're a careful observer, that the mercury toxic patient in a man is a pretty masculine man overall, a pretty kind of, you know, the sort of sense you get about when somebody has mercury in the mouth, they're pretty rough and toxic, but you know, they kind of certainly have maintained their masculinity. The moment you replace their fillings and put plastic in their mouth, they lose some of that male edge. You know, that's sort of the first observation most of you will have made, consciously or unconsciously. And so, unfortunately, at this stage, there isn't many solutions, and we're hoping there is one solution I know for sure that has worked, and that is using the argon laser as a light curing device. You know, the light curing makes decides on what length of carbon fibers these plastics are. If they're short lengths, those are the estrogen-like substances. Yeah? And if you cure with the blue light, you unfortunately only get these short length molecules which have estrogen effects. If you use an argon laser, the netting is longer, the molecules become longer and get out of that estrogenic range. The argon laser has one disadvantage, is that the material becomes a little bit brittle. It becomes a little harder than it should be. Now, there's a company touting now the xenon light as an ideal compromise, which creates a little shorter change, but they're not long that they're brittle, but they're longer than being out of the estrogenic range. I called this company 11 times, the main researcher, telling them that I was going to do some research on their light, and they avoided me like the plague. They have not returned 11 phone calls. I'm suspecting that the whole thing is a fraud, and so I can't recommend it right now. But I do know that the argon laser works. If you have some environmental ill patient, a cancer patient, somebody who isn't at the tops of their health, I do think that using the argon laser for curing light is an ideal new step of getting past the risk of the plastics. And the amazing thing is that filling materials that were allergenic before are no longer allergenic when you put the argon laser on there. The other good thing about the argon laser is that the blue wavelength is highly bactericidal, virucidal, and fungicidal. That means you can sterilize a tooth. You can take an affected tooth with a pulpitis, shine a laser on there, and the tooth is completely bug-free afterwards. It kills the bugs in the tooth. And there's some papers published in the early stages of the argon laser where they just had two groups of people. One group they lasered every tooth in the mouth, and the other group they didn't. And the group that was lasered, for 5 years nobody had any decay, and the other group went on and have their normal decay on a regular basis. So it's also ideal prevention for tooth decay. So just some nice new stuff. The company with the xenon light that I mentioned is a company that markets Diamond Crown, which we were all hoping was going to be the ideal material. And we know from the test that it is more allergenic in general than Conquest. The guy at Hal Hagen's clinic who does the blood testing there clearly has that impression. However, we were hoping that Diamond Crown was going to be the ideal material. I do have a feeling, though, there's a highly touted company that is great in marketing, and the reason we all believe that there's this new light on the horizon is their marketing skills, and not so much that they have anything new.
Dietrich, when you mention the argon laser, are you talking about the contact laser that will actually also cut tissue, or the non-focusing?
No, the non-focusing just as a curing light. They're about $7,000 a piece. Yeah, Terry. Yeah.
Dr. Reniger has one of those.
Who makes those?
Doctor Who? Oh, you have it. What's your impression so far?
Well, we're using that as well as the diamond crown, and we've been doing up to 7-unit bridges without any. It's like, we're putting the rib on in them, but it's like amazing how much harder it is, and I haven't had any of really fracturing.
Great. So far so good.
ILT or ILT.
Yeah. So you have a good sense about it.
I like it so far.
Great.
Who makes the
Yeah.
argon laser?
I have an argon laser from ILT, and my experience has been excellent with it, but the service and the stand behind the product of ILT is absolutely zero. And I'm very close to being in a very large lawsuit with them because of the fact that our laser's been down for almost 2 years now. And so at this time, I recommend the LaserMed one. The LaserMed is excellent because you can not only dial in the time, but you can also dial in the frequency, and they actually do testings of your individual composite to find out exactly what frequency and how much time you should cure it, because they know that too much time makes it too brittle. Not enough time doesn't totally cure it. So.
Do you have a phone number for that? I mean, could people call your office and find a phone number? Or could you, as a compromise, could you call in the number to Carol Arana so she becomes the switchboard for that? Is that okay? Yeah, so you guys call Carol in a couple of days when he had time to look up the phone number and call it in. Let's not do too much questions. Okay, yeah, you were.
Creative has a argon light also that I've been using, and it's remarkable. It works fantastic.
It's not argon.
They claim it to be an argon.
No, they don't.
Well, that's how it was sold to me.
Well, I've got one.
But you like it?
Oh.
I know Creative also makes a xenon light. It makes the least expensive xenon light. Oh, great. Yeah, yeah. But would you also call Carol with the final account of the information? Because it's a very new area, you know, and I know the idea behind it is very, very important. But there's a lot of companies now kind of trying to move in the market very quickly, and before they have the staff and the support system, they have a product and selling it to you, and then, you know, things like that happen. LaserMed, here, see the address, the phone number is 800 903 2873.
Really looking.
Salt Lake City.
Okay, thanks. Can I keep this card? Okay, thanks. Yeah, Mrs. Issel?
May I ask an advice which might be helpful for many? We have noticed with several advanced cancer patients who were in remission that after amalgam replacement or removal, it couldn't be halted anymore.
Yeah.
There was such an enhancement.
Yeah, yeah,
Would you suggest
yeah.
for such?
Well, we developed a whole protocol of how to protect the patient during the procedure and afterwards. You know, and my main agent is chlorella. You know, I'll show you some overheads afterwards that we now have proved that chlorella removes huge amounts of lead and mercury, and cadmium and nickel through the stool. Yeah. Also, like everything we know about mercury detox in this country is based on urine tests, which is the wrong place to look. Yeah. Most of you are cool enough to know now mercury does not appear in the hair. It's in the brain. It doesn't go in the hair. If it was in the hair, there's no problem. It gets out. Yeah. The mercury is in the brain and the nervous system. It's not in the hair. So when you do a hair analysis, it's a complete worthless test. The only time mercury shows up in the hair is if you successfully remove it. If you give a DMPS shot, for 3 weeks afterwards, it shows up in the hair. If you do chlorella on an ongoing basis, mercury shows up in the hair. If you do DMSA, mercury shows up in the hair. If you don't do anything that effectively removes the mercury from the cells, through the connective tissue, into the blood, from there into the gut, if it appears in the blood, it appears in the hair. But if it's not in the blood, It ain't getting onto the hair roots. It's not coming out. So the hair is the wrong place to look. The urine is the wrong place to look, because only in people that have significantly impaired bowel circulation, the mercury will appear in the urine. The urine is the last organ the body wants to put the mercury through. It gets the gut surface, the secreting surface in the gut is the size of 2 tennis courts. That is what the body is using to excrete mercury. However, we have an enterohepatic circulation. That means the mercury slowly moves through the gut, and unfortunately in the last part of the colon we have a lot of sulfhydryl binding groups in the colon surface, and it reabsorbs the mercury there. So what we had to do for the detox is, first of all, we had to look in the bowel what comes out, not in the urine. And this is how I got onto the chlorella. And here we are back to the IV vitamin C. IV vitamin C we used to do based on empiric evidence. Then some idiots like me and others came around, looked in the urine, couldn't find any mercury in the urine after vitamin C, went around teaching to others, stop the vitamin C, it doesn't work, even though the empirical evidence was there that people do much better. Now we looked in the stool, and lo and behold, there's huge amounts of mercury coming out in the stool, far more than with the DMPS shot when you give IV vitamin C. So we're back on doing IV vitamin C as a protection during the amalgam removal whenever you can do that. It has been proven clinically to be a winner. There's been a lot of voices, including my own, that said it's bullshit, it doesn't work, because we looked in the wrong place. So I'm revoking that now and tell you I was wrong, many others were too. Do the IV vitamin C. Clinically, we always know it works, but some of us, our minds go off with certain ideas.
Where this side of Dusseldorf, Germany, do we have a laboratory that will measure the stool?
Tübingen. I set up the laboratory at the University of Tübingen, and we've had the chance there to do a number of tests on testing our different procedures. The DMPS is very, very effective. The DMPS, the mistake is done here often. You look in the urine, you get only 5 micrograms coming out. The patient says, I'm feeling a lot better, since the DMPS shot. And you idiot, me idiot, said, well, it's probably the sulfur in the DMPS or something else at work, because there's nothing coming out in the urine really that's significant. So let's go another way, and go off for 2 years doing something different with the patient. But where we overlooked that he had maybe 2 grams of mercury coming out in his stool on that day. Yeah? So be aware of those issues. Unfortunately, the laboratories here in the US have been highly unresponsive to my demand of developing a stool test. Dr. Stater, the great smoke lab, they developing all kinds of useless tests, all kinds of useless test panels based on somebody lecturing on some idiocy stuff. And this is hardcore stuff that is so important, and no lab had dedicated any dollar or amount of time to develop a test. Now, Dr. Stater, he has promised me since 3 years, oh, next month we're going to have it, next month for sure, because they're afraid to lose me as a customer, but nothing has been done that is tangible so far. So be aware, chlorella, many of you have listened to my chlorella lectures. You can get a protocol from my office if you want to, or for that purpose from Carol Arana, like we're going to have the protocols here on how to use chlorella effectively. Chlorella has turned out to be an absolute winner in the stool test, far beyond our beliefs. Vitamin C, when given IV, has turned out an incredible winner. It's useless given orally, but IV, not useless for other things. There may be purposes for doing it, but IV has been turned out a winner. It's about 37.5 grams to 50 grams in 500 cc's distilled water, infused over 2 hours is the dosage that has been effective. 25 grams is too little. So it's a bottle and a half of the conventional pack.
Considering how well vitamin C is absorbed orally, why do you think it doesn't work orally compared to IV?
Well, I think it needs a bolus effect. The bolus effect is a certain concentration in the blood that has to be above a certain limit, and then it pushes the vitamin C across the arterial walls into the connective tissue. And if the level stays beyond a certain level, it doesn't get pushed in the tissue in high enough amounts.
Isn't it 750 milligrams per kilogram? Isn't that what it is?
The IV vitamin C?
Yeah.
I don't know. I use for depending on size. If it's a big person, I use 50 grams, and if it's a smaller person, I use 37.5, which is a bottle and a half to 2 bottles.
To prevent reabsorption by rectum, shouldn't we do enemas during this?
Yeah, a very good question. You have to combine the vitamin C. We checked it. You know, if you only do the vitamin C alone, most of the mercury gets reabsorbed before it leaves the body. And there's 2 ways that you can prevent that. One is if you load the system with chlorella before the IV vitamin C. 30 capsules of chlorella is a good average dose that's tolerated by everybody, no matter how sick they are. 30 capsules, yeah. Remember with the chlorella also is the issue. Chlorella does 2 things. It has a membrane that absorbs mercury and other toxic metals. Aluminum, very effective for aluminum and other metals. However, it also has methylcobalamin and other substances in it that mobilize mercury. So there's 2 effects it has. One is it shakes the tree, and a lot of mercury starts coming out of the cells, and the body gets tremendously toxic from that. And then it has a membrane that absorbs some of these toxins. Now, there is a certain curve. When you give small amounts of chlorella, you get a lot of shaking of the tree and very little absorption and carrying out of mercury. That means the person gets more toxic. Their feelings of toxicity increase with low doses of chlorella. And then at about 12 to 15 capsules, it's about even. About an even amount gets carried out as gets absorbed. That means with 12 or 15 capsules a day, that's a maintenance dose where the patient doesn't feel much. And if you go 20 or 30 capsules, you carry more out of the body than you mobilize. And that's where it becomes effective. And so we've been following that symptom for years, and people give up on the chlorella because they put people on like 3 capsules and 4 capsules to try out, and the patient comes back and is dead, sick like a dog, They say, well, he's allergic to chlorella, he doesn't tolerate it. What they're feeling is the mercury toxicity created by it. The mercury, it lives inside the cells. You're dying slowly, but you're feeling pretty well. You're feeling kind of dead and numb, but nothing acute happens. When the mercury leaves the cell and comes into connective tissue, it gets in contact with the autonomic nervous system, and things get hot. You get inflammations, you get pain, you get nausea, you get migraines, you get depression, you get all the symptoms on the way out. Reykjavik called that regressive vicariation, those of you who know it's homotoxicology, when the toxins move out from inside the cell to the outside. That's where the havoc is created, not when it's inside the cell. You slowly die of cancer and arthritis and those things. But it's peaceful and nobody minds you. You sort of slow in your chamber and nobody minds you. When you're out there and you're kind of in obvious visible pain, everybody wants to avoid you because we're sympathetic beings, and that's sort of when we're called on the scene is actually when things are happening in the right direction. John?
Can we put to rest this notion that you hear from patients that have read Huggins that vitamin C will counteract the local anesthetic?
Yeah, the local anesthetic issue. Now, vitamin C does induce some liver enzymes that increase local anesthetic breakdown. However, this is by no means a complete and total issue, and what I highly recommend is do the vitamin C during the removal and start the IV before you start your injections, everything, and it won't interfere to a significant degree. Remember, we have now also the Stabidan anesthesia system, which is much more effective than the nerve blocks. Well, Dr. Almayan is going to talk about that after my talk. Let me out of respect, one more question, yeah.
Thank you, yeah. Yes, are you familiar with the glutathione?
Yeah. Mm-hmm.
We have a new product now in the United States, also in Germany. So glutathione seems to be very important in detoxification of mercury.
Yeah.
And I would be interested, what experience do you have with glutathione?
Yeah.
Because myself, I made about 60 years ago, my doctor, dissertation on glutathione.
I know, yeah.
I'm happy to hear
yeah.
we have a drug, Immunocal.
Yeah. Immunocal, yeah. Mm-hmm. Yeah. There's a few words to glutathione, N-acetylcysteine, and the other substances that are used, DMSA. There's a guy lecturing around Freckleton who touts the DMSA now as the ideal compromise for detoxing patients. Now, glutathione, N-acetylcysteine, and succinic acid, other substances that are naturally occurring in the organism, are great for detoxification, except with one warning. If you give glutathione or N-acetylcysteine, it gets in the gut, it gets absorbed very nicely, and as soon as on its path it encounters mercury, it binds to the mercury. But that's not the end to the story, unfortunately. Then the glutathione goes, and the N-acetylcysteine goes wherever the cysteine or the glutathione is needed, which is often inside the nervous system, inside the brain. So these molecules will bond to the mercury on the way to the brain and take the mercury into the brain. When there is significant mercury toxicity in the body. So DMSA will do the same thing. There have been a number of cases documented of children being given DMSA and then developing seizure disorders from lead and mercury being dragged from the body into the brain. Yeah? And so our sequence, and I'm not against DMSA, please hear that clearly, DMSA is a firm part of my detox protocol, but I do recommend to first clean up the body from here on down by using DMPS shots or chlorella or both until there is an IV vitamin C in high dose, which does a wonderful job in removing extracellular mercury. And then, when nothing is coming out anymore, then you do your DMSA protocol. And the DMSA protocol, write it down, it's 500 milligram, 1 capsule, every other day, for 2 months. Then you do a 2-month break, and you repeat it for another 2 months. So you do 2 months on, 2 months off, until the patient is well. And typically, about 3 to 6 weeks into the first course of DMSA, the patient starts feeling tremendously well. They get a tremendous sense of well-being. Yeah? Now, you can do that if you do not want to do chlorella, if you don't want to do vitamin C, you don't want to do DMPS because it's not a completely legal drug to use yet. Then use the DMSA anyway, but know that you have a risk, a relatively small risk, but a risk of making the patient worse. Yeah? But you do something. DMSA is under the name Chemet, available from the PDR, but we use it as a custom compound drug, which is 5 times less expensive. Yeah? And that's a protocol under the physician heal thyself part that I'm lecturing on here, that every one of you in the room should do. You should do at least the DMSA. If you're not, you know, for some reason you don't want to inject yourself with DMPS, and for unknown reasons you don't want to take chlorella, and you don't want to do IV vitamin C, and you can't be bothered, at least do the DMSA, to get your brain back. It is a way to get your brain back. Okay, I could cover this whole thing, but Michael, since you're a friend, depenicillamine, yeah, depenicillamine works quite well. There's a program by Russell Jaffe, but it is very slow. It is very slow. You really have to give it for 2 or 3 years before you reach any substantial levels of detox, but it does move mercury out of the brain cells and out of the cells. So depenicillamine, there's a protocol you can get from my academy, I forgot what the exact dosage is, has a challenge test and has a long-term protocol that is very safe, even though depenicillamine is the most toxic of these substances on its own, and you cannot use it on people that have cancer or are environmentally ill. So it's limited in its usage.
Does DMSA or DMPS remove anything good, from our bodies?
Well, in the rat studies, which is interesting, it has been shown that you could inject rats with nearly lethal doses of DMPS every day, and they would only lose the minerals in the beginning that were in excess, and then no longer lose any of the essential minerals. So the myth that DMPS and all these things deplete people significantly is a myth. However, rules change when you have a sick patient. Sick patients have damaged blood-brain barriers, damaged cell barriers, and they lose their good minerals. And so it is important to supplement minerals abundantly. Yeah? I really want to go on, because it's like a boring issue to most of us.
Questions, because we're really behind. So
Yeah. So this was just regarding the plastics and the mercury. There's one issue. The other issue we have in dentistry is the infections in the jawbone. I've got a lot of things to say about that. So one, the root canal issue for me is like a settled issue. The root canals in general are bad. A root canal tooth that is filled with biocalyx. Biocalyx is a calcium hydroxide compound from France. is by far a better material than the other materials that were out. And root canal teeth filled with this material, if it's a traumatic injury like from ice hockey, where the tooth wasn't infected to start with, and the root has died from overheating. I had some people that drank from a too hot cup of water and the tooth died, or traumatic injury, then biocalyx root canals seem to stay good for about 10 to 12 years, and then the natural process of time, the decay products in the tooth from the dying tooth are too severe and it needs to be removed. But for cosmetic reasons, you can maintain certain teeth for an extended period of time with that material, in my opinion. Now, this is one man's opinion based on my testing that I've done, and it's confirmed pretty much by Boyd Haley's affinity labeling of the few teeth that were done like that we tested. We didn't find any toxicity in the first few years of these teeth. However, in general, root canal tooth is a dead tooth. We know that. Gives off all kinds of substances other than the bacterial toxins from there, and in a sick patient should be removed. Remember again, like, there is a big difference that the conclusions drawn on your observations on healthy people are not applying to sick people. I'm always getting in confrontations with doctors in Germany and all over the world who derive their experience on treating people that have colds and sores and shoulder pain. My practice is dedicated to chronic neurological illness, ALS, MS, Parkinson, and to cancer. And in that group, observations made in this group do not hold true in this group. And so if you have a sick patient and they have a root canal, 1 root canal or 10 root canals, they have to come out. No compromises about biocalyx, forth or back, it doesn't matter. But if you have healthy patients, a healthy young ice hockey player who knocked out their front tooth, I suggest that you're quite safe doing biocalyx as a root canal. It's my opinion. Now, I know it's going to be conflicting with a lot of things, but this is my lecture, so I'm kind of getting my point here. Now, let's talk about you know, like posterior teeth, you know that the loss of height. Now, there is a good study that shows people that have dentures live 10 years less, have 10 years less life expectancy than people without dentures. And in that study, people were included that did have root canals and did have implants and other things to maintain their no denture thing. So we don't know all of it. We have, like, many of us have derived our experience on the cavitation issue and that on sick patients. And there certainly the rules change. A sick patient does not tolerate any infections in the mouth and they have to come out. And so with the infections, I'd like to say a few words. You know, we've been looking at the infection issue at first like, well, there's a localized event like an abscess. Let's take it out and the patient should get well. Then we found with the operations that about 40 to 50% don't do well. They do well for a few days, for a few weeks, and then it comes back. Then our next step was to look in the autonomic ganglia that are responsible for the innervation of this area, and found that the same toxins we found in the jawbone we find in the sphenopalatine ganglion, in the otic ganglion, in the vagal ganglia, in the sympathetic ganglia in the front of the neck. You operate the tooth, the bugs retreat into the ganglion, they wait until you're gone, and boom, they're back in there. And it's a game. Doundra showed that that also the site that you operated becomes, through its increased inflammation and circulation, becomes a site that selectively extracts toxins that are circulating in the bloodstream and accumulates them. He did a study on formaldehyde where he had to reoperate a cavitation site 27 times before no more formaldehyde was deposited in there. That means what we did, we used the cavitation site as a way of detoxing the body. That means we operate, we take out a bunch of toxins, and the body puts more in there. The body says, great, this is now my route of exit, so he puts more toxins in. So we take it out again, 27 times. Now, my suggestion is, it's not an elegant way to detox the body. We have other ways of getting formaldehyde out of the body, of getting metals out of the body. Yeah? The brain, let me just make a quick drawing that you will understand how that works. This is the brain. Okay.
It's your brain.
Our brain looks exactly like an octopus, and these things here are the cranial nerves. And the way the brain becomes toxic from mercury is not through the blood dumping it in there, because we do have a blood-brain barrier. It's pretty effective. The brain becomes toxic because the cranial nerves are absorbing the toxins at the end, the mucous membranes in the mouth, the mucous membranes in the nose and the sinuses. This is where the toxins enter, and through axonal transport, they end up in the brain. The brain has no barrier from the cranial nerves. These are like the open vulnerable spots that the brain has. And the funny thing is, like when you detox the brain, this is going exactly in reverse. And at the end here, this is where your bone cavitation is, for the trigeminal nerve. The fifth cranial nerve ends in the cavitation. And so when we remove the toxin here, it's like a joke to think that removing the cavitation is going to be the end of the story. Within a few days, you're going to have the same toxins that made this bad to start with trickling back down here on an ongoing basis. And this is why Ara, who was going to lecture after me, developed this ingenious idea that we could drill little holes in there and vent the area, inject it with antitoxins, with antidotes, with antibacterial agents, and neutralize the toxins as they're coming out here and create little holes so the stuff can perk out and the membranes here can be loosened up so this can kind of drain into the general circulation. Now, this works wonderful, but only if you then catch the toxins as they come up in the blood. If you don't catch them there, they're going to recirculate around and kind of come via the bloodway back in here. And it's an endless story. And so the main thing we have to do general detox measures, and we have to often operate the cavitations to get the main bulk out, but that's not the end of the story. Then we have to stay with them, that we have to treat this area sometimes for months afterwards before the story is ended and the patient is well. And this is how we get our MS patients well. We haven't gotten them well. With the operation alone, we often get half of them or a third instant success, and they're well, they're over the threshold and they're tipping back into wellness. But with this procedure, by understanding this mechanism, we get another 40 or 50% that we couldn't get before. Yeah? So this is a radical new thinking, but it's very logical and the science is out on this. And remember the other cranial nerves, there's the olfactory nerve, which is responsible for a lot of mercury going up into your limbic system. You're sniffing it and it goes straight in your limbic system, screwing up your emotions. Like most of your dentists here are damaged in the emotional area. I mean, there's plenty of scientific literature that confirms that. And it's not that you're bad, it's just that you're toxic in the limbic system, and it has to come out the same route. And Downerer found a very simple way of doing that, and it is sniffing the MPS. You just, every time you inject a patient, you put a little bit on a piece of glass or on a dish. You just sit there and sniff it without the patient knowing it. This way you don't have to pay for your treatment. You just take that extra drop, you sniff it, and you detox your limbic system that way. Yeah? We want to put the antitoxin at the end of the cranial nerves, and this is what modern neural therapy has become. We use DMPS at the end point of the cranial nerves, which is, by the way, the trigger points. Up in this area is the spinal accessory nerve. It's one of the cranial nerves. We put DMPS in the trigger points, and immediately it's in the brainstem. We can trace it with our testing. Immediately kind of goes up into the brainstem. We can put it in the masticatory trigger points, which interestingly, the vagus nerve, the trigeminal nerve innervates, I believe, the masseter. So the trigger points in the masseter directly transport DMPS up into the brainstem to the fifth cranial nerve ending. So we have ways, we can sniff mercury at the first cranial nerve. So we have like ways of using the cranial nerves to get into the brain. And that's a completely new way of thinking. And it's been radical, what that has been doing for our patients. The improvements are outstanding with that.
Would it help to mix a little DMPS with a little alcohol and put it on the tongue? Would that have the fast road to the brain?
Yeah. I don't personally think you need the alcohol because DMPS is very readily absorbed on the tongue. But that's a hypoglossus nerve. It's another nerve that needs to be detoxed. And they all end up in the brainstem. You can pump up as much DMPS into the brainstem as you want by using those natural routes. Yeah? We have a treatment where the patient reclines on the table. We show that in neural therapy courses with the head hanging backwards so that the nostrils are parallel to the ceiling. And in this position, anything you drop in the nose ends up in the maxillary sinus, which is innervated by the glossopharyngeal nerve and by the autonomic nerves, the parasympathetic nerves, and it's the ideal way of detoxing the vagus. Yeah? So we don't have to inject the vagus anymore. We just kind of, patient reclines, we drop a little DMPS, DMSO, procaine into the nose. It gets in the maxillary sinus and gets all taken up within less than an hour and ends up in the brainstem. Well, procaine opens the membranes. Yeah, it's a big membrane opener, so it enhances absorption. Yeah. Let's take this to the side again. Chris, have me putting this to the
So how much
to the side.
DMPS do you put in? Just a few drops each nostril?
Or half a cc, like per treatment, once a week is a good idea. Quarter cc on each side. But each maxillary sinus holds about 5 cc's of fluid, so you can use a total of 10 cc's. So I put a few Sanum remedies in there. To treat the upper jaw infections, it's ideal to put the Sanum remedies up in the maxillary sinus, then they sit down on the sinus floor and slowly trickle down onto the nerve roots of the upper teeth. So your pefrakeel, your arthrochelan A, notocheel are ideal. Sanum remedies, a few words about those. I couldn't live without them anymore. Like to treat dental infections, we have always the option of giving long-term antibiotics, which you have to do, or giving long-term Sanum remedies. They're both evenly effective. One has significant long-term side effects. You got to deal with the candida and the cleanup afterwards. The other one has no side effects. However, to pick the right Sanum remedy, you need to have some guide, either electroacupuncture or muscle testing, to find out which one, because there are several options. We have a course in June on the use of Sanum remedies in the mouth. Those of you who want to get familiar with it, I recommend you take it. That's where we go over all the details of which remedy for what condition and how to test, and the different options you have. But we don't. Is it in Phoenix? Scottsdale. Yeah. Maria has the details on the course.
June 11th to the 14th.
Yeah. Those of you who haven't used the Sanum remedies and want to get familiar with it, I think it's a must for every dentist. A tip for those who are already using it: the vials are sometimes hard to get and they're expensive. The oral drops are cheap. Both have the same ingredient. The oral drops are sterile when they come to you. So if you dedicate a dropper bottle of oral drops, they've got 5 cc's in there for a price about a quarter of what the ampoules cost. They are not pH adjusted, so they hurt a little bit more, and it's a little bit more elegant to use the vials. So if you can get the vials, it's better, but if you can, as a backup, you can use the oral drops. Then you have to go do all the precautions of sterility and all that and keep it in a safe place. But
is the tonicity okay, or just pH?
What?
Tonicity, it's the same tonicity.
No, it's different. You have to mix it with more procaine to make it painless, but it works very well. Yeah. But in the Stabident procedure, we still prefer to have the pH, tonicity, and all that adjusted in the vial. But you can use the oil drops if you have to. Okay, so for treating the bone cavitations, we have to detox the whole body. We have to look what are the circulating toxins that are getting there. The infections are not just in the cavitation, they're in the autonomic ganglia and the sensory ganglia that innervate the area. We have to treat those. So we have to do neural therapy to treat the ganglia. We have to repeatedly treat this cavitation. The Germans, like we said yesterday, treated the cavitation after the surgery every day for 7 days, and then every other day for another week, and then slowly faded out the treatment. The idea that we had here, well, we take the stuff from Germany, but we Americanize it. McDonald's, instant. We do one thing, we take the one thing that looks logical to us and forget that there's a whole other thing that made the thing work, that we sort of cut off, and it doesn't work like that. But the understanding is pretty advanced now. So this is like a little bit on the infection issue. I just want, it's my State of the Union thing, kind of saying where we are, what we've been doing. Ara's going to lecture on the Stabident procedure, which for me has been the biggest breakthrough in the infection cavitation issue, in the issue of preventing root canals, where it's probably the most valuable of all the procedure, and also in diagnostic neural therapy, finding out which tooth is causing a sciatica. The injections to the gum were nice. Dr. Gladdish's system is far more intelligent. It's the best system out there, the most elegant, non-invasive system that I've would love you guys to please take that home and try it and work with that. And then the most invasive, non-invasive treatment is the Stabilian procedure that Ara's going to lecture on, which every dentist I feel has to do. You have to commit to doing that, even if you just use it for diagnostic nerve blocks to see which tooth is causing your sciatica, or your migraines. That's the only way to find out. Well, it depends on how much time you give me.
Well, we're supposed to be in a break right now. It's 10:15. We're supposed to break at 10.
Oh, already. Okay. So let me just kind of do 5 minutes. Okay.
Save your questions for the end of the day. We'll have like a panel at the end of the day. How's that?
So.
Talking to the microphone, please.
Oh, okay. So the last issue, of course, is the bite. That we know that the correct plane of bite is important. Occlusion, each cusp of the tooth can be off a little bit. Any of these things can give you tremendous distortions in the autonomic chaos and the sensory chaos coming into the brain. And the decision whether to take a tooth out or to maintain your bite is a decision that needs to be weighed very carefully. All of the TMJ guys and all of the MDs that seriously look at these issues, that sometimes by destroying somebody's bite, by taking care of the root canals and infections, is making the patient worse because you're adding this new component of a lost bite. And dentures, partial dentures, are a good solution, but they're not always acceptable because of the plastics allergies. Remember, the pink material, the thing that makes plastics pink in the mouth, are mercury-based colors. Colors are devastating to the system.
They're all metal. The colors are all metal.
The colors are all metal.
They're not all
mercury. And I was going to show you a bunch of slides on other things. Let me just kind of now do 2 minutes on physician heal thyself. I feel like the most important, there's a couple of important things you should do for yourself that are very, very important. One is, most of us have screwed up hormones because of the xenobiotics and the environmental toxins on their estrogenic characteristics. And I personally like a 24-hour urine study. I use the Tahoma Clinic in Kent, Washington. That's Jonathan Wright's clinic. I feel like by getting a 24-hour profile, you get a random sample that monitors the different bursts and lows and highs in the hormones over 24 hours. It correlates excellent with clinical, and you should correct all the hormonal dysfunction that you find by using the hormones, the natural hormones from Women's International Pharmacy. We have the main person is here. If you need to talk to somebody, is it okay if I kind of, I know you're not being paid for that, but she's the main person, and they've done the major piece of work. If you don't have your hormones in the ballpark, you can take all the vitamins in the world, and they won't do you any good because the cellular command isn't there to take them in. You have. Carol? Yeah. Sorry for doing that to you, but since you're here, and it's such an important piece. So I feel any one of you who hasn't done the 24-hour urines, I don't like the saliva test. It's been highly unreliable when we correlate it with blood tests. I don't like the blood tests because they're so expensive and they only get a peak for that moment. So I like 24-hour urine, but there's room for negotiation. But get your hormones in the ballpark. Please, please, please do. You feel so much better and you get your life back. Then for the vitamin issue, the nutrition issue, we use the Body Bio. It used to be Carbon-Based Corporation, now it's Body Bio Corporation. It's a normal blood test. It's put through computer analysis. It calculates all the ratios and all the different relationships of the things in there and comes up with a nutritional program that's really excellent. It's called the Body Bio Corporation. I don't, of course, have the phone number here, but Carol will have that phone number if you want to have that. Those are the two tests I feel are a must. If you have a sick patient, like my expertise is on cancer and chronic fatigue and chronic neurological disease, you need to have the red cell membrane fatty acids. Red cell membrane fatty acids, the fatty acids are determining the health of the cell wall and the organelles in the cell. These are 67 different fatty acids. You do the test, it gets put again through computerized analysis and comes out with the best currently available nutritional program that says if you need to eat more protein, what oils you should eat, which ones you should avoid. So these are 3 things I feel everybody should do regularly, at least once a year, to monitor the ballpark of where you are with your health. Lee? I have it, 609 825 9554. Thanks, Lee.
Lab for the fatty acid profile.
They do the same. They organize the test. They have the computer program, to analyze those tests. Yeah, they do both. Yeah. Okay. Well, thanks for. I was going to do a lot more on the autonomic nervous system. Maybe just the neurology. Yeah, just the 2 minutes. Thanks. Okay. Thanks, guys, for listening. Yeah.
I thought that Meridian Valley Clinical Labs was Joe Reiser's.
Yeah, Meridian Valley. It's the Tahoma Clinic, Meridian Valley Lab. The same thing.
I use them, yeah.
One quick announcement, there's been a revolutionary dental material produced for amalgam replacement for all the dentists and all the doctors here that want to test and use this material. It was developed by Dr. David Izumita. He has the test kits. It is actually a conquest material with actually spectra fibers in there. Most of the testing on there from energetics wise is very clear and clean. It has actually the mechanical retention. You don't have to bond. It's probably one of the finest test materials that we're going to use some research on. It's been 7 years of research. It's very pulp compatible. It seems to save and prevent root canal teeth from occurring. The literature is on Carol's table. They're going to donate part of the funds to the Academy, and they'll also set up research members to do research on there. Also, I'd like to quickly, those patients that we treated yesterday, a quick profile. Will they stand up right now and just give a quick rundown of their improvement?
I'm already standing up. My shoulder's about 70% better.
Next. Who else?
My shoulder's about 90% better.
Okay, next. Who else?
The same with mine. Mine's about 90% better.
Okay, next.
My back, I had a little glitch this morning, but this is remarkably better.
Okay, next. Who else do we do? Yes? These service from anyone else? Anyone not be? Yes?
My mouth is a little bit better.
Okay, Bob? You had,
Yeah, it's about 60% better. It's getting better since early this morning.
Bob had a cavitation about 2 weeks ago, and he's had problems with it. Okay, all those patients that we did do this work on, I want to see you all again at some point during the day to recode. And the material is called Compress. It's on the table over there. There's a dental machine up there set up. You can test the hardness of it. We can talk about it. I'll be over there also. Thank you.
Let's take a break, and we'll be back. Take a half-hour break, please.
Front, so we'll start it.